Thank
But
you, everybody, for coming to our clinical conference for this month. I'm really excited to have Dr. Peggy Nguyen, who is here, who is our neurocritical care physician, giving us an update on stroke management because I think I'm a little like rusty on it as well. So with that, I'm just going to turn it over to Dr. Nguyen.
all right, hello everyone. So I do like to be a little bit less formal. So if at any point anyone has any questions, please feel free to just unmute yourself or pop it in the chat if I don't see it. I'll try and answer it at the end of the talk. But today we'll just be talking about stroke management. And well, I focus primarily on ischemic strokes just because stroke, if you include hemorrhagic strokes as well, it becomes a really big it's a big topic. But I feel like the majority of strokes that are seen and managed, frankly, by internists are probably more ischemic strokes in general. So I have no relevant financial disclosures. And we'll talk about both acute ischemic stroke management as well as some updates in secondary stroke prevention. And hopefully all of this will be somewhat relevant for everyone. And I always like to frame things around a case because it it helps me remember things. But this is a very typical, classic kind of, stroke patient who might come into, I mean, at Keck, I guess they wouldn't come into the ER, but a typical stroke patient that might present to the hospital in one way or another. An older patient with all your typical vascular risk factors and recently diagnosed AFib coming in with right-sided weakness and difficulty talking. And let's say this patient was with her daughter, and her daughter knew she was at her baseline 2 hours before coming into the ER. And she's on your typical kind of medications like aspirin, metformin, atenolol, amlodipine, and torvastatin. She doesn't really have any other lifestyle risk factors for stroke. She doesn't smoke, and she does use a walker to ambulate, but it's not necessarily because she's had a history of stroke or anything like that. She's had a meniscal injury. This is actually a patient I saw, I think, last month or so. She's otherwise independent. So, of course, the first thing we always do for an acute stroke after we see the patient is a CAT scan, right? And these are, and I guess these are this is the question for the group to think about. This is actually not the MOC question, but this is something to think about. What are our treatment options for this patient? If you have this patient coming in, clearly symptomatic, and what looks actually like a pretty normal CT head. You can do anything from, these answer choices. So do you do aspirin, atorvastatin, and admission? Do you do clopidogrel, atorvastatin, and admission? Aspirin and clopidogrel, a thrombolytic, and then plus or minus further imaging. What I think is really cool about acute stroke, at least in the past, really it's been 10 years, is that depending on when I ask the question, the answer is actually pretty different. And I feel like the answer, even when I was a resident in training or a stroke fellow in training, is even different from what my answer would be now. So for the longest time, all we had was TPA and alteplase, right? That's all we had for forever and ever and ever. Um, and this is one of those things that I think, for neurologists, is not controversial. TPA obviously works. The NINDS trial, which was published in the New England Journal in 1995, demonstrated that patients who received TPA did much better than placebo. And I didn't put the entire study up, but I just put a small chart up from the New England Journal of Medicine, which is on the right-hand side. But what we often look at from stroke studies is the modified Rankin scale, which is a scale of independence, essentially, and function after having a stroke. And 0 is basically completely normal, no symptoms whatsoever. And then 6 is death. And what's considered to be a good modified ranking scale is usually around a 3 cutoff, because 3 is sort of the cutoff where you can still walk even if you need some help. And so you can see that patients who receive TPA, there's a shift in how patients scored on the modified ranking scale. And patients who receive TPA were much more likely to have a better modified ranking scale at 3 months. This is 3 months outcomes, right? So on the basis of the NINDS trial, the FDA approved TPA in 1996. And what's interesting is, they only approved it up to 3 hours. And then in 2013, the AHA actually expanded the window to 4.5 hours, which is why if you hear any of us, talk to patients about TPA, it's always up to 4.5 hours. And that was because of additional clinical trials, although there were certain exclusion criteria applied to this extended window of 3 to 4.5 hours, including like older age, if you're taking anticoagulant, large stroke, so NHO scale greater than 25, or if you have a history of diabetes and prior stroke. Um, Interestingly, even though the AHA recommended it, the FDA never actually expanded the approval of TPA beyond 3 hours. So it's never been FDA approved for 4.5 hours, technically, but it is AHA recommended. And so I would venture to guess that most stroke neurologists or most neurologists who are doing acute stroke do TPA within 4.5 hours and not just the 3 hour limit. More recently, the 2019 guidelines actually updated the eligibility criteria for TPA within this expanded window and and took away some of the language that set it out as a contraindication. So, you know, studies beyond this point, beyond 2013, did find that people who are very elderly, beyond the age of 80, do have more complications, but they still benefit. And so the contraindication for age was removed. The history of concomitant diabetes and stroke was removed. And then the wording for these large strokes with an NHO scale greater than 25 was reframed so that it's not contraindication, but it's reframed so that we say that the benefit is uncertain. And that's where I think your stroke neurologist comes in, because that the onus should be on us to talk with families when someone has a really large stroke about whether or not it's beneficial or not. And I think we have to be honest and say, it's still recommended. It's not as clear that it's going to be as helpful, but it is still recommended. And then patients, even if they are on an anticoagulant, although I should specify really it's warfarin, um, if their INR is less than or equal to 1.7, should still receive TPA because INR is not reflective in patients who are on a DOAC, right? So that was the 2019 guidelines. So I said, for the longest time, all we really had was alteplase. A lot of stroke neurologists, a lot of neurologists would say that we borrow a lot and we uh, not steal. We borrow a lot of ideas from cardiologists. And, cardiologists have been using tenecteplase for the longest time, right? A lot, much longer. And so I think in the stroke world, people are thinking, well, alteplase and is good, but there are some things that are just not as ideal with alteplase. Um, One is it depletes fibrinogen quite a bit, which is actually thought to be the mechanism for post-TPA hemorrhages. And it also has some other things like it's very annoying to administer because you have to give a bolus and then administer the rest of it over an hour. And if you are working in an institution that's more of a drip and ship model where you give the TPA in the ER and then send to someone else, which is how Keck actually receives most of our TPA patients or stroke patients, is they go to an outside ER, they get the acute treatment there, and then they send them to Keck, right? So if you have that kind of model, then it can be a lot more difficult in terms of transporting these patients because you need to have certain critical care transport and things like that. So there are definitely advantages to tenecteplase. Um, Tenecteplase is also like the half-life is longer than alteplase. And so they started doing studies actually on tenecteplase and stroke probably in the 2000s or so. And there were a lot of studies, which I definitely am not going to go over here, but I will go over very briefly just three of the more updated studies. And I wish I did this in chronological order, but the three really large randomized trials on tenecteplase all occurred within the past like 6 years. The ACT trial, the Extend IATNK, and the TASTE trial. And all of these trials used the same dosage of tenecteplase, which is 0.25 milligrams per kilogram. And it was all for patients who were presenting within the same window that they would ideally receive TPA, so 4.5 hours. ACT was the largest trial with 1,600 patients, and all of these were really, well, I shouldn't say all. The ACT and TASTE were both non-inferiority trials, And what they found was that, at least for ACT and TASTE, they met their primary outcome. It was non-inferior to TPA. And for Extend IA, they found that there was more reperfusion in patients who received tenecteplase compared to TPA. And you can see the numbers. It's actually a pretty significant increase or difference. And more importantly, there was no real difference in their safety outcomes. So the rate or percentage of symptomatic ICH was the same between TNK and TPA, and death was not significantly different. One would argue from Extend IA that maybe it's less, but I believe the actual p-value is not significantly different between TNK and TPA. And so on the basis of these three trials, this was very exciting for everybody. Tenecteplase received FDA approval for stroke just earlier this year. Again, it has a much higher fibrin specificity. It has a longer half-life, and it's much, much easier to administer. I think what's really interesting too about the TPA transition to TNK is that even though the FDA approval only happened earlier this year, it's actually been used, tenecteplase has actually been used in a lot of stroke centers, even prior to this, starting around 2020 or so. Um, a lot of centers switched over from TPA to TNK. And if you're thinking about what happened in 2020 and why it made a difference, of course, that was when, COVID was happening. And so one, TNK, like I said, is a lot easier to administer, and there's less face-to-face time that the nurses need to do when you're doing TNK because it's a one-time push and that's it. With TPA, because it's that push and then that drip over the hour, there's more face-to-face time. And so TNK was, if it works, it's preferred. I think the other reason, there's an article about this, but another reason why TNK kind of took off during that time was because I think there were a lot of concerns about potential supply chain issues with TPA. There were early on, I don't think it quite bore out. But early on, I remember there were a lot of studies looking at TPA and in patients who had developed a really bad ARDS from COVID. And so there was this fear that, there wouldn't be enough TPA to go around essentially. And TNK actually was cheaper than TPA. So even though the approval only happened this year, a lot of centers have been using it for many, many years. So that's actually very exciting. But the other thing that's also really exciting is if we had seen this patient, and I guess that's interesting. If I had seen this patient back in, say, 1999, my answer would have been, okay, give TPA and then admit, right? If I saw the patient now, then I say, well, you can give TNK. And then if I'd seen the patient in 2015, this patient has another option for treatment. And it's because at the heart of it, there are patients who have occlusions, and you would think it's kind of like a plumbing issue. And if there is a plumbing issue, there should be a plumbing solution. It's kind of like if a cardiologist can go in and do an angioplasty and a PCI, why can't neurologists? And they actually tried for a really long time. I didn't put them up here, but there were a lot of trials preceding this for thrombectomy that actually all failed. And it was probably because they weren't selecting the right patient population. And of course, it's always a question of how do you select the right patient population? And I think it wasn't until 2015 when we finally got it right. And then when we got it right, we really got it right because we had, five major thrombectomy trials all published the same year, kind of around the same time. I think it was actually a coordinated effort to that demonstrated that thrombectomies actually worked. And the big one that's always referred to is the Mr. Clean trial. One, because it was the largest trial. You can see that actually the other trials all stopped early, part of it because Mr. Clean was positive and the clinical equipoise was no longer there. It's not really fair to randomize patients to a treatment that you know is going to be inferior anymore. But these trials essentially proved that in the right patient, thrombectomy is better than what would have been standard medical management, which after TPA at that time, after TPA would have just been admission and then, aspirin or whatever it is that you're using after, right? The times are actually pretty variable in terms of the enrollment, but when they did additional meta-analysis and things like that, essentially what they came up with was patients who had a disabling stroke, so an NIH stroke scale of 6 or greater, who had a fairly preserved CT scan. So stroke neurologists use something called an aspect scale. I don't remember if I have it later, but we use something called an aspect scale, which is a scale or a score looking at a non-contrast CT head, and you grade it based off of how much stroke there is in that hemisphere. It's really MCA hemisphere. And you start at 10 if there is no stroke whatsoever. And if the entire part of the brain is, if the entire thing is stroke, then I guess you basically take points away, so it's 0. And so the higher the score, the more preserved the brain is. The lower the score, the more stroke there is. And so if you have a aspect score of 6 or greater, meaning more preserved brain, and if this could happen within 6 hours, then you were a candidate for thrombectomy. So it's actually one of my fellows pointed out, it's a 666 rule. It makes it easy to remember. 6 hours, NHO scale 6, and aspects of 6 or better. Um, but essentially, all of the studies found that the modified Rankin and the functional outcome and independence was all better. All of these things were better in the thrombectomy group. What I thought was really interesting was that there was actually in the ESCAPE trial, in the 2015 ESCAPE trial, there was actually a reduction in mortality too, which we often talk about stroke causing a lot of disability, although not necessarily mortality. And so I think finding a mortality benefit is really, like, it's really cool. It's really beneficial. So yeah, so we saw this patient in 2015, 2016, then the answer will be TPA and then thrombectomy. And how to evaluate for thrombectomy, you do a CTA because you have to demonstrate that there is an LVO or a large vessel occlusion. So this patient actually did have a large vessel occlusion, and she underwent a successful thrombectomy, and she actually got much, much better. I think when I saw her next day, she had a tiny bit of word finding difficulty, and she had a little bit of right leg weakness, but she swore up and down that leg weakness was because of that meniscal injury she had. So I don't even know whether or not the leg was truly weak, which is really, it was just a really great outcome for her. But let's say, I know everyone knows where I'm getting at. Let's say there's a different last known well time. Let's say we don't know the last known well time. The daughter found her when she came home or something, and she brought her in really quickly. Do we have any different treatment strategies? And, I just finished telling you, like, well, you have to do TPA or TNK within 3 to 4.5 hours. And you should be doing a evaluation for an LVO if it's within 6 hours. And a lot of you probably know that thrombectomy is an option actually up to 24 hours. But what I think a lot of people may not be as familiar with is that TPA actually might be a treatment option, even with an unknown last known well time. Because at Keck, I don't think we have our wake up protocol up and running. We've talked about it and it's probably going to happen, but I don't know that we have a wake up protocol up and running. But in 2018, yeah, in 2018, there's a really cool trial called the Wake Up Trial, looking at TPA versus placebo, which is no acute treatment, in patients with an unknown time of onset for stroke. So either they couldn't report what time the symptoms happened, or they like woke up with it, but you could not be beyond 4.5 hours of symptom recognition. So if you went to bed at 10 p.m. last night, you woke up at 6 a.m., you could still get enrolled in this trial so long as you came in within 4.5 hours of waking up at 6. So 10:30. So at 10:30 a.m., you could potentially still be in this trial. And if you had an LVO, they did exclude you because you're probably going to get a thrombectomy. And you have a really large stroke, they would exclude you as well. And the basis of this is imaging. They were looking for a DWI flare mismatch because what humans cannot tell you, sometimes technology can, right? So flare actually does not turn positive immediately. DWI is supposed to. DWI turns positive immediately with a stroke. But flare is actually a delayed reaction. It's vasogenic edema, so that takes time to occur. So when you do an MRI on someone, the flare actually does not tend to turn positive until about 4 to 6 hours after someone has a stroke. And so the flare is going to tell us if it's been within the upper limit of the time period where we still feel comfortable giving TPA. And this is what your ideal kind of MRI should look like if you're doing this for a patient who has a wake-up stroke. So A is someone who has a matched DWI and flare MRI. See how the DWI and the flare is like, it's pretty much all gone. But for patient B, there's a little bit of motion artifact on the flare, but there's a large area of DWI changes in the cortex here on the right, and there's really not a corresponding flare change. And so this patient B is someone who would be enrolled in this study. And of course, everyone knows that's not, but would benefit from TBA. So what they found was that there is a shift in the modified Rankin for 0 or 1 at, I should say 3 months or 90 days. Sorry, not 390 days, but at 3 months or 90 days, and it was a significant difference. There was no significant difference in death or inability to live, although there was an increased risk of parenchymal hemorrhages. So that is a caveat. You have benefit from this particular treatment with the caveat that there are more hemorrhages. Although if the hemorrhages don't lead to a significant difference in death or inability to live independently, then it's probably worth it. This is another one of those situations where I think the onus is really on the treating stroke neurologist to have that conversation with the family. A wake up protocol is not available everywhere, but if it is, then it is part of the newest AHA recommendations that it is reasonable to offer TPA in these situations. Um, there weren't enough studies looking at TNK and wake-up stroke at the time that the AHA guidelines were published and updated. I think there might be one somewhat recent one with TNK, but it's not been really adopted yet. So most people, if they use a wake-up protocol for patients, will use TPA over TNK. Okay. Okay. And then earlier I had said that I think a lot of people realize this by now, but we obviously do thrombectomy beyond that 6 hour window now. We go up to 24 hours. And similar to the idea of, using the right imaging to look for patients who benefit, like with MRIs and this DDI flare mismatch. I think it was all a matter of looking for the right imaging criteria, or at least the right criteria to find patients who could benefit beyond 6 hours. Because what we know is that everybody is different, right? Like that's not even a stroke thing. Every patient is different, and everyone's cerebrovascular reserve is different. And there's this concept of an ischemic penumbra where you have stroke at the core, and then outside of the core stroke, there's penumbra that includes areas that can spontaneously reverse, so like benign oligemia, and then there's penumbra that can reverse if you get to it on time. And whether or not someone progresses from penumbra to stroke really depends on what your collaterals are like, how long the stroke has been there, and what your personal sort of functional state and metabolic state is, right? We don't really have a good way of measuring, at least for the long time, we did not have a good way of measuring some of that, the functional metabolic state or collaterals. So really what we were going by was the duration of the insult or the stroke, which is why everything's very time-based. 4.5 hours, 6 hours, nothing beyond that. But then we had these studies in 2018, Dawn and Diffuse 3. Keck is actually one of the highest enrolling sites for Diffuse 3 trial in 2018. And they used slightly different criteria, but essentially what they were also looking for in both studies was a mismatch. In the Diffuse 3 trial, it was purely an imaging mismatch of core and penumbra. In the Dawn trial, it was a mismatch of a clinical of the clinical syndrome with what the imaging looked like. I actually think that's really hard to sort of go by when you're making acute decisions. I think a lot of people go by the Diffuse 3 trial imaging criteria just because it's very easy. But they randomized these patients to thrombectomy versus just, standard of care alone. And what they found was that there was, again, a benefit, a shift in the modified Rankin in favor of you doing thrombectomy, even up to 24 hours, 16 hours in diffuse 3, but 24 hours in Dawn trial. And there was no significant difference in hemorrhages. There was actually a mortality benefit in the diffuse 3 trial for thrombectomy, 14% versus 26%. And the p-value is just barely significant. So this is an example. So this patient actually did have a CT perfusion as well. And you can see that this patient, the purple is the core, and it's a really small core. The cerebral blood flow less than 30% indicates the core, and that's 6 mLs. What we really look for is a core of less than 70 mLs. And then the green is the penumbra, and we're looking for a penumbra greater than 15, and a ratio mismatch of greater than or equal to 1.8. You can see the mismatch ratio is 13. Now, technically, this perfusion mismatch is really the most important for patients beyond the 6 hour window, because this is what we used in the diffuse and Dawn trial. So technically, you don't have to have a perfusion scan in patients who are presenting within 6 hours. But I think the best code stroke algorithms work when they are quick, rapid, and consistent every time. So a lot of places that have a really good code stroke algorithm will do CT head, CTA, and CT perfusion all at the same time. Um, Again, Keck doesn't have an ER, so I think if the consulting neurologist wanted to kind of, decide based off the time. Like if they wanted to get a CT head and CTA without the perfusion, then it's less than 6 hours. I think that's very reasonable, um, because technically you don't need it. The studies that were all within that 6 hours, they did not use perfusion and certainly didn't use these criteria. Okay. And then the last thing I'm going to say about acute stroke is I spent all this time saying, first I spent all this time saying we need to do it within a certain time. And then I said, okay, but then realize that you have to have an aspect of 6 or greater because you have to have enough preserved brain. The newest thing is that you would think that getting a clot out is better than leaving a clot in, even if the aspects is, say, 5 or 4, because doesn't 4 or 5 mean there is still some brain to salvage? And of course, a lot of people thought that too, which is what led to a bunch of these clinical trials for what we call large core strokes. So I feel we're basically just expanding potential treatments for everybody. um, because now it's no longer just you can only get TPA if it's within 4.5 hours. Now everybody can get treated. But they did actually quite a few studies looking at large core strokes because I think that is the thought process, right? One of our neuro surgeons or neurointerventionists has said, at the end of the day, if you have a humongous stroke or if you have blood within that stroke, it's injured brain anyway, because that was usually why, or that's why we don't do thrombectomy for really large strokes, because there's this risk of reperfusion hemorrhage. And it's like, well, it bleeds. It's a stroke, like it would have been stroked out anyway. So why not try, right? Um, but there are these multiple clinical trials for thrombectomy for large core stroke, and they enrolled patients with aspect scores actually really low, even down to the 0 to 2 range. Although most of them had an aspects of 3 to 5. And I don't actually think this was even published yet because this was just presented last month. There have been news reports about the results, but I don't think it's actually been published yet. And they did find that patients benefited. So if you go by a modified ranking of 0 to 2, 19.5% versus 7.5% who did not receive thrombectomy. If you go by 0 to 3, almost a third versus 19%. Um, 19.5% is not a huge number, but it's still a benefit. There were more symptomatic hemorrhages. I think that's something that none of us are surprised by. But since mortality isn't really different, if anything, or maybe it's a little better. But since mortality isn't different, then again, kind of like with wake up trial, isn't it worth trying? Right. So again, acute stroke imaging, we get a CT head to basically rule out hemorrhage for thrombolytics. We get a CT angiogram to evaluate for thrombectomy candidacy. And then perfusion, really you need that within the extended window, although most places do everything all at once, just because you want to have a good algorithm each time. And so this is kind of like a general confusing algorithm you can kind of consider if you are unlucky enough to be seeing a stroke patient. But if it's within 4.5 hours and your imaging, if at any point your imaging shows a bleed, then, different story. But if your imaging doesn't show a bleed and doesn't have an LVO, then the the patient's candidate for a thrombolytic. And now you have a choice of thrombolytic. TNK is at KEC though. So, and it's so much easier to use. It's the same inclusion and exclusion criteria. We essentially use it interchangeably with TPA. If there is an LVO and no bleed, then you can do TNK or thrombolytic and thrombectomy. If it's within 4.5 hours to 24 hours, and certainly within the 6 hour to 24-hour window, then you do want to get a CT perfusion. If there's no bleed and no LVO, you can actually consider doing a wake-up protocol. You just have to try and get them to MRI really, really quickly. And that's why this is never a situation really where you would, do TPA per wake-up protocol before going for thrombectomy. Because if they qualify for thrombectomy, they should be going for thrombectomy. We shouldn't be taking them to MRI to get TPA in. And if there's no bleed and there's an LVO, then they qualify for thrombectomy. Okay. Think, yeah, I think that was the end of the acute stroke part, which good, it's about halfway through. So the big things I think is new thrombolytics. So TNK is now FDA approved, even though we've been using it for a while, it's actually approved. There's an expanded eligibility for thrombectomy. I mean, I think we all already knew thrombectomy was a viable option from 2015 studies, and then even expanding that to the 2018 studies up to 24 hours, and then now even potentially large core strokes. Sort of at the discretion of your neurointerventionalist, but I do not discount recommending thrombectomy for a large core stroke, particularly if it's someone who's very functional at baseline. At the end of the day, I think really is what are we potentially salvaging? And there is an MRI protocol for thrombolytics for strokes with unknown last known wall time. Okay. Um, for some reason, I know. Oh, there's something in the chat. Oh no. Hang on. Oh, okay. Not a question. Okay, good. All right. Let's talk about some secondary stroke prevention things. Secondary stroke prevention is never quite as exciting as acute stroke, but a lot of ischemic strokes are actually lacunar, which means that a lot of ischemic strokes at the end of the day really need sort of like really good cardiovascular, cerebrovascular risk factor management. Once someone's had their acute stroke workup or acute stroke treatment completed, the rest of the inpatient management, I often have to tell families, the rest of the reason they're in the hospital is so we can figure out why their stroke happened. And and all the tests we're doing is really geared towards identification of the stroke etiology. And so what that usually entails is some form of cardiac monitoring, even if it's just a simple EKG, some form of non-invasive vessel imaging, whether it's carotid ultrasound, MRA, uh, MRA of the head and neck, CTA of the head and neck. By and large, all of our patients get a CTA anyway as part of that initial stroke workup. So we don't usually have to figure out if they need an MRA or not. Um, MRI of the brain, so brain imaging, risk factor stratification, specifically lipid and A1Cs, and then an echocardiogram. Most strokes, again, are lacunar, and then there's a minority of strokes that are like cardioembolic or cryptogenic and large artery. And I'm going to just talk about the secondary stroke prevention for each one. Um, I do have here, and I won't talk about this that much because this essentially is the algorithm that the AHA guidelines recommend for how to work stroke up inpatient. And essentially, it's just the studies that were mentioned on the previous slide based off of whether or not there's a stroke, whether it's anterior or posterior circulation, which honestly, they say if it's not an anterior circulation infarct, you can get non-invasive intracranial and extracranial imaging of the vertebrobasilar artery system, which doesn't really make sense to me because no one does an MRA of just the vertebrobasilar system. If you're doing an MRA or a CTA of the head or the neck, it shows everything. It shows anterior and posterior. So it doesn't really make sense to me that they, portioned it out. But essentially, if none of the workup shows anything very specific. You still don't have a cause. mean, number one, obviously get us involved, but that's when we start looking at other sort of atypical stroke workup things like long-term cardiac monitoring, whether that is something just for 24, or sorry, for 2 weeks, or it's a implant for a longer period of time, very uncommon causes like vasculitis, things like that. Okay. So again, vascular risk factor management, all these things are pretty typical. I feel like one of the really common questions I get from patients in my stroke clinic, who are referred to me from primary care. Actually, usually I get a lot of patients from primary care who have had a stroke in the past, and oftentimes it's more like a referral just to make sure that they are on the right medications and doing the right things. And they'll say, but my lipids weren't that bad. Do I still need to take my statin? Um, and sometimes I feel like it's really hard to convince them, yes, but yes, they still need their statin. It's interesting, I had a patient who had a stroke in the past, came in with a second stroke, and the patient's spouse said that the patient was not put on a statin because they did not want to put them on a statin because they were worried about the risk of Alzheimer's and increased risk of diabetes, which I just thought was very interesting because even with the second stroke, they did not want to be in a statin. And even for studies that suggested a mild increased risk in diabetes for patients who are at risk for diabetes already, this patient was not diabetic, his A1C was like 5. Um, the American Diabetes Association still recommends, as they should, a statin because the cerebrovascular and the cardiovascular benefit far outweighs the increased risk of diabetes. But people are just, for some reason, very scared of statins. I'm not sure if you guys have experienced this in your outpatient practice, but I feel like my stroke patients are very frightened of being on a statin as opposed to things like aspirin or clopidogrel. But anyway, we have stroke studies for that. The Treat to Stroke trial found that LDL less than 70 was better than a less conservative uh, goal of 90 to 110. And that's why our goal is less than 70. And then even patients who don't have another indication for stroke, atorvastatin 80, which is considered a high dose atorvastatin, did reduce stroke recurrence in patients in the Sparkle trial. And there's actually another trial that I didn't put here, but it was in patients who already had an LDL less than 70, not on a statin. There was still a benefit for them to be on a statin for stroke prevention. So it's very rare that I don't have patients on a high dose statin. It's more common that my patients are supposed to be on it and they just decline. Okay, let's talk about some antithrombotics. So, aspirin is obviously our mainstay. There is no significant difference between aspirin versus clopidogrel, and that was demonstrated in the Capri trial. The Capri trial did find that there was a benefit it was a composite outcome of MI, stroke, and other ischemic events. Primarily, I think it was peripheral vascular disease. And there was a benefit with clopidogrel, but then when they broke it down, there was no benefit for stroke, and it was all driven by reduction in peripheral vascular disease. So, you may see people on clopidogrel instead of aspirin if they were on aspirin and they had a stroke. And so it's considered like an aspirin failure. We don't have good randomized controlled trials to actually say that that is the right thing to do, but a lot of people certainly do it. And then aspirin, dipyridamole has been studied in a couple of different trials, and there was no difference compared to clopidogrel. And you could argue if there's no difference with clopidogrel, and clopidogrel has no difference with aspirin, then maybe there's no difference compared to aspirin. Um, yeah, there was no difference. Aspirin versus aspirin dipyridamole, I don't know why I can't say his name, but in a Aspirin ESPS2 trial, it's also there may have been a slight benefit for the aspirin dipyridamole group. And so any three of these options are actually probably reasonable for long-term stroke prevention. Silocizol is a really interesting one because it's actually been studied in in the Asian population. There were two randomized controlled trials, CSPS1 and CSPS2, which were all done in a single, it was in Japan. And there did seem to be a benefit with the lositazole, but since it was a single population and it has not been reproduced in other populations, the last 2019 guidelines did not have a recommendation for silocizol over aspirin. It basically said unclear benefit. Um, I have very, very rarely, when I've had patients who, for whatever reason, cannot tolerate aspirin or clopidogrel, and they don't want to try the aspirin dipyridamole because it has aspirin in it. I have used cilostazol as an alternative, although I tell them it is not FDA approved for stroke. It's FDA approved for peripheral vascular disease, and it's not recommended yet necessarily by the HA guidelines, although there are trials that do demonstrate its efficacy. Um, and so all of these are potential options for your patients for single antiplatelet therapy for long-term stroke prevention. There are certain patients who will benefit from dual antiplatelets, and it's either going to be a high risk TIA or a low NA stroke scale stroke. And that's based off of two trials. Now these are older trials. These were Oh gosh, let me think. Yeah, this one came out when I was a resident. So these are older trials by now, but the CHANCE trial came out in 2013, and patients were put on clopidogrel and aspirin for 21 days and then clopidogrel alone. And they did find that there was a significant reduction in recurrent strokes at 3 months, driven by the reduction in ischemic strokes, and there was no increase in hemorrhagic strokes and no increase in moderate or severe bleeding events. There was a follow, I say a follow, but there was a similar trial. So Chance was done in China. There was a similar trial done in the US, the Point trial. And there are some differences with the Point trial compared to the Chance trial. But the Point trial randomized within 12 hours. But what they did was a longer duration of clopidogrel and aspirin for 90 days instead of 21 days. And they actually found that there was a benefit in terms of the composite of ischemic stroke, MI, and death from ischemic vascular events, and there was a benefit for ischemic strokes. Although there were more hemorrhages, major hemorrhages was increased in the dual antiplatelet group. However, when you actually look at the curves for aspirin versus the clopidogrel and aspirin group in terms of the benefit in term like the recurrent strokes and in the safety outcomes, the lines, the slope actually doesn't really change after really it's probably close to about 2 weeks or so. Like the lines really diverge early on, and then the slopes don't really change all that much after that. And the difference in safety outcomes don't really become significant until after 30 days. When they did post hoc analysis, secondary analysis, this was found to be true as well. I do think that there were probably more hemorrhages with the Point trial compared to the Chance trial because they used DAPT for a longer period of time and because they actually used, I didn't put this here, but they used a higher loading dose of clopidogrel. So essentially, on the basis of these two studies, it is recommended by HA to do DAPT for 3 weeks for someone with a low NA stroke scale, high ABCD2 score, and then after 3 weeks, you transition them to monotherapy. Longer term, it just seems to increase bleeding risk. Thales in 2020 was a really large study, slightly different because these were slightly larger strokes in a stroke scale of less than or equal to 5 and high risk TIA of greater than or equal to 6, and they had to have some kind of stenosis. And this was ticagrelor with aspirin. And there was a benefit for ticagrelor with aspirin, although with more bleeding events. But this actually led the FDA to approve ticagrelor for stroke in 2020. So you can also use ticagrelor, although I think most people for a low NA stroke scale or high risk TIA, I guess technically, unless it's a NA scale 5, because it falls outside of chance and point, most people would use clopidogrel and aspirin over ticagrelor and aspirin. Now, if you had an intracranial stenosis, so that's the other etiology, right? So if you have a intracranial large artery atherosclerosis, I'm going to go a little faster because I realize I'm running out of time. Aspirin is always preferred over anticoagulation. And you have a couple of different options. You may see us use a couple of these things, but I mentioned Thales, which demonstrated efficacy with the ticagrelor with aspirin if you had some form of stenosis. And then DAPT still, aspirin and clopidogrel. So even though for these small strokes, there was an increased risk of bleeding if you continued it for a long period of time, for patients with large vessel intracranial stenosis, the Sampras trial did demonstrate a benefit um, with aspirin and clopidogrel for 3 months. So this is almost always the only time we ever use DAPT. Either DAPT short-term, 3 weeks for a small NIH scale or low NIH scale, high-risk TIA, or 3 months for intracranial stenosis. But the point is that we don't do it long term. I've had a lot of patients come to me who had a stroke years ago and they're still on DAPT, and I am shocked that they haven't bled yet. Against cilostazol, it's like the odd one out. There have been some studies for cilostazol specifically with intracranial stenosis, not FDA approved, although the AHA guidelines do have a recommendation that it is reasonable, possibly, if you have stenosis, to use cilostazol. But I think most of us use aspirin and clopidogrel because of Sampras. Okay. I'm not really going to go over carotid. This is essentially carotid stenosis right now because I think there's not that much new in the world of carotid stenosis. We already know moderate and severe, moderate depending on certain things. There is a benefit for revascularization. And I will put this here because I think if this is posted, if you want to peruse these studies or look at these graphs, you can. This is a pooled analysis of the really uh, those seminal trials looking at carotid endarterectomies. Uh, and basically there's a benefit for patients with moderate to severe stenosis. Although for moderate stenosis, there was really no good benefit in the first 2 years, and then it reversed after that. So if someone's going to have a life expectancy of less than 2 years, it's probably not worth it. So that's the caveat for moderate stenosis, right? There is an update for asymptomatic carotid stenosis, and this was just, if I had given this talk when I was supposed to, like 2 weeks ago, this wouldn't have been published yet. I think this was just published last week, and it's unfortunately probably going to change my practice because CREST-2 enrolled patients with high-grade asymptomatic stenosis in two arms, carotid stenting versus CEA, and there was no benefit for CEA, but there was a benefit for the stenting arm. Um, they looked at 4-year composite of any stroke or death, and patients in the stenting arm had much less strokes and death. So I was talking to one of my neuro IR friends, and he is anticipating a deluge of more patients with asymptomatic stenosis. I think if you actually look at their event rate, it's not that high per year. It was like 1.7 or 1.8%, which is not that high. So we have to realize that we're not, going from 10% to, it's not 10% to 4% or something. It's not that big of a difference. More like 1.8% to, I think, zero point 0.5 or 0.6% per year. So it's not huge, but there is a benefit. But that will unfortunately probably change my practice. And it may change yours too. The very last thing I'll talk about, because it is 12:54, I'm so sorry, is cardioembolic stroke. The biggest thing I think is we are restarting anticoagulation earlier and earlier because we used to be very scared of restarting anticoagulation after a stroke because of the potential risk for hemorrhagic conversion. Even the AHA guidelines actually still say like 2 to 14 days. And we used to say there's a rule of thumb, 1 day after if it's TIA, 3 days after for mild, 6 for moderate, 12 for severe strokes. But there have been multiple clinical trials that have demonstrated that it is probably safe to restart DOACs, not necessarily warfarin. They didn't look at warfarin in these. These were all DOAC trials. DOACs within as early as less than 4 days after a stroke. And there was no increased risk of major bleeding, and there was a benefit in terms of less strokes. Most of the patients in these trials were actually on apixaban, and they did a patient level meta-analysis of four of these large trials. So there were over 5,000 individual patients, and there were enough patients that had very severe strokes too. 12.5%, 12.5% of patients had an N scale greater than or equal to 16. And they looked at early restart versus delayed restart. Most common DOAC was apixaban, and there was a decrease at 1 month composite of recurrent stroke, symptomatic isolation, other unclassified strokes, with the benefit primarily seen in recurrent ischemic strokes at 30 days and no difference in symptomatic ICH. There's always the caveat if you look at the inclusion criteria, it's like, well, some of them use some imaging things and criteria and things like that. So always at the discretion of the physician, but it is probably safe to restart earlier than we used to. And the very last thing I'll say is if they just don't tolerate anticoagulation, there are options for left atrial appendage closure. There have not been to date any trials that I can find for left atrial appendage closure versus DOACs. The Protect AF and Prevail trial and the registry trial. Registries, which were registries for Protect and Prevail, were really with warfarin. So we don't have anything with DOACs yet. But there is a benefit because there's obviously less bleeding with the atrial appendage closure, although there's probably still a benefit for ischemic stroke with warfarin. But if your patients can't tolerate it, then it is an option. So the big updates in secondary stroke prevention, I think number one, the use of dual antiplatelets in the immediate acute setting in those high ABCD2 score, low NH scale patients, and then limited dual antiplatelet therapy, not long term, but for either 3 weeks if it's acute for those patients, and then 3 months if it's for intracranial stenosis. Ticagrelor was FDA approved for stroke about 5 years ago. Silostol is not FDA approved, but there's pretty good evidence for it. And I think DOACs can be restarted earlier than traditionally thought. I think a lot of neurologists are still actually wary of restarting DOACs that early. Anecdotally, I have started DOACs pretty early, and I have not had any hemorrhages, and the data supports that. And then now we know asymptomatic severe carotid stenosis might actually still benefit from stenting, but not CEA. Okay, so I feel like this question is going to be very obvious. The answer is going to be obvious because I've been saying it over and over again, but this is our MLC question. So if you have a patient who's coming in with a lacunar stroke and their NHO scale is 1, which would be the best antithrombotic strategy for stroke prevention in this patient? DAPT times 3 weeks, and then clopidogrel, DAPT for a year, and then clopidogrel, aspirin alone, warfarin lifelong, or cilostazol monotherapy. And I can't remember what we said. They're not going to put the answers in the chat, right? They're sending it to you, Jennifer.
Yeah, email me,
Okay.
Jennifer,
Okay.
Sabra. You guys,
Yes.
I'll just put everything in the chat if you
Okay.
guys can't
Perfect.
remember.
Okay, so since it's 12:58, I'm just gonna give the answer right now. But it's aspirin and clopidogrel for 3 weeks because I feel like that's like the one thing that I kept saying over and over again. It's really just because I get so many patients who have been on aspirin and clopidogrel for 5 years, for 10 years, and they're like, I don't know, someone put me on it and I just never got taken off of it. But there's no, at least for stroke, we have not found a benefit for long-term DAPT. Maybe we will at some point. I don't know. Stroke is changing all the time. But for now, there's really no benefit beyond 3 weeks for these small strokes or 3 months for intracranial stenosis. Thank you. I'm sorry I talked for really long. That actually took a little longer than I anticipated.
No, no, no. Thank you so much. It was great. We really needed the updates. I'm glad that there was so many new like articles that just came out this year, actually. That is like that's changing the
I I mean, I feel like acute stroke is a really quickly changing field, I feel like. I don't know. Neuro IR really brought a lot to the field. I think the things that we still don't know yet, and there's still a lot of conflicting data, is a lot of neuro IR stuff. Like, do we go after medium vessel strokes if they're M2s? And some people will, some people won't. The latest data says it might not actually be beneficial. What about basilar strokes? How much time is too long before you go after that because if you don't do anything, they're probably going to die. Um, there's, a lot of stuff about, well, what's the right blood pressure after a thrombectomy? And then I think there was something new recently from maybe World Stroke Congress where they were saying that patients with TIA, at least, we should probably be lowering their blood pressure earlier than we currently do because right now the recommendation is permissive hypertension. Um, so I don't know. There's always something.
There's a lot of changes. It is at 1 o'clock, so I just want to remind everybody, Jennifer posted the CME credit in the chat for everybody to put in, and then also to email her with the answer to the MOC question. And please include like your date of birth as well as your medical license number in that email so that you can get credit for the MOC. But since we are at
Great.
one, I'm gonna let everybody go. If you guys have any questions, I thought I saw like your email in one of the PowerPoint slides, but is it okay if we email you with questions if we have any?
Email me with questions. I can stay for a little bit if someone has really pressing questions, but it's also the Wednesday before the holidays, so people who just need to get on the road or anything like that, that's very reasonable too.
Thank you so much. And thank you everybody for joining. Happy holidays, everybody. Happy Thanksgiving for tomorrow.
Yeah. If you're traveling, travel safe. Bye.
Yes, thank you so much.